Good afternoon and welcome to our last presentation of ANAwareness Week 2021. The team from Mayo Clinic has been gracious enough to spend this week with us sharing information and answering questions on various topics important to the AN community, and I'd like to thank them once again. It's been a great experience for our organization, and I'm sure all of our attendees have learned a great deal. We're here today with our second Ask the Docs panel. Right now we have with us Dr. Colin Driscoll and Dr. Brian Neff. Both are otolaryngologists and otologists from the Rochester campus. We hope that Dr. Lundy and Dr. Chaichana will be joining us shortly, but they have gotten held up at this point. Before we get started, I want to go over how our presentation is going to work today. All of our attendees are muted, so you're only able to listen. If you have questions throughout the presentation, you can just ask them in the questions box. You click your toolbar and that'll pop up and you can type them in there. If you're on Facebook, you can just type them into the comment section. You should be seeing captions at the bottom of your screen. If you don't, again, go back to that toolbar and you can press click a captions button. On Facebook, you may have to adjust your settings and activate them there. We are recording this presentation and it will be in the presentation section of our ANAwareness Week landing page. We'll also have it on our Facebook page and in the video library. You can find out everything you need to know about ANAwareness Week. You can see past presentations and find out lots of information about acoustic neuroma on our website. That web address is www.anausa.org. And if you want to get to the Awareness Week page, you can just click the slider on the home page and it'll take you right to that spot where you can see all the presentations. Some of them are taking a while to upload, so they are not all there yet, but we will get them there as quickly as possible. All right, Dr. Driscoll and Dr. Neff, why don't you go ahead and introduce yourselves? I'm going to stop sharing my screen.
I'm Dr. Brian Neff. I'm one of the surgeons here at Mayo Clinic, Rochester, with a strong interest in helping patients with acoustic neuroma. There's 3 of us here and 2 of us are on. So,
where is that third one? I'm Colin Driscoll, one of the neurotologists. I work alongside Dr. Neff and have had a long interest in vestibular schwannomas and management, helping people make decisions and choose the right course for them. I'm hoping we can get some of the folks from the other sites on board today as well, but just like everyone's job, sometimes it bleeds into time when you don't plan that to happen. I think we can cover lots of different things this afternoon during the next hour. If there's some questions that we know are covered pretty thoroughly in a different session earlier, Melissa can maybe highlight those and refer people back to other conversations we've had. And once again, just a shout out to the ANA for all the support they've provided to past and all the support they provide to future patients with vestibular schwannomas or acoustic neuromas.
We appreciate that.
I think there are some questions already submitted.
We do have a couple questions already submitted. I want to ask you quickly first, what would you say is one of the most common questions you get from patients or something that you hear frequently from patients, or does it depend on the size? Are there questions that you hear pretty frequently?
Yeah, I think there's a lot of questions that we hear, pretty universally. Mm-hmm. And then there's things that I realized I didn't address up front as much as I probably should have, that were just obvious to me, but not obvious to patients. And one of those things was normally if something's wrong, you go to the doctor and you assume they're going to make that thing better. So if your knee hurts, you go in, you get your treatment, and your expectation is you're going to get better again. If you have a vestibular schwannoma and it's caused dizziness problems or it's caused hearing loss, your expectation is you're going to come in and see Dr. Neff, and Dr. Neff's going to tell you how to get your hearing back. And we can't do that. So usually when the hearing's gone, it's gone. If you have some dizziness, well, you have a tumor on your balance nerves. It's not surprising you have dizziness, and we may not be able to improve that. You might get better, but and so I think I've missed the boat on that one over time in a way, and then you get to it eventually through the discussion, but. I think it is important to recognize that this is a little bit different than some other aspects where we're not able to restore function, but we're looking a little bit more towards the future and how do we manage your tumor and preserve function that people do have.
One of the sessions that we had earlier this week was on surgery, but we really didn't talk about CSF leaks. And so there was a question in that session that we didn't get to that asked about how long post-op is it considered safe in regard to CSF leaks? How soon do most of those happen? And when can you feel like you're kind of in the clear there?
I can feel this one. I think most of them happen in the first 2 weeks. So, if you get beyond that, I think there should be some relief, but I will tell you, my personal patient record is 20 years later. So there's never a point where I guess where we say it's impossible, but I think the vast majority of them happen in the first few weeks, and out of that, most of them happen, I think, in the hospital. Quite honestly, that we notice them when they first are getting up and walking the halls. So.
We talked in one of the sessions, and we do get a lot of questions about this. About MRIs and serial imaging and things like that. But this question is actually about the margin of error in measuring vestibular schwannomas. So does it vary by machine? Does it vary by the radiologist who reads the MRI? And is it enough of a difference to be significant if it does happen?
So this brings up a couple of important things to understand. There's a standard way that we measure and report acoustic neuroma size. So if we're writing a paper and we're separating tumors out by size, we're measuring, usually we are measuring a single dimension horizontally in a particular orientation of the part of the tumor that's inside, I'll say inside the head, not the part that's in the inner ear canal. So if you think most bigger tumors sort of turn into an ice cream cone shape, and the cone part is in the internal auditory canal, and then the ice cream is the part that's coming back towards the brain. And we're more interested in that part of it. So there's a horizontal measurement made there, and then sometimes a vertical measurement. And we basically look for the greatest dimension. We ignore the part in the inner ear canal. A lot of radiology reports will include that. They're measuring the longest distance. So it's important to just understand that there are different ways to measure and report it. And then this came up the other day too. There's a big difference between millimeters and centimeters. So you have to look at the unit that was utilized. There's no difference between machines, really. There are different techniques. And so you can think of the clarity of the picture is different. So sometimes we're going to get a fuzzy picture. Well, where does that exactly start and stop? I don't think most of that is not super important, with the exception of MRI scans are slices. And so there's the slice thickness. How many slices do you do through the ear? Is it 4 or is it 400? And so if it's 4, or let's say there's 5 millimeters between slices. If your tumor is 4 millimeters, theoretically, you could miss it, not see it at all, right? And so the slice thickness also impacts the ability to maybe accurately measure it. I think at the end of the day, it doesn't make too much difference in that you do need, once you identify the tumor, if it's really important to know early on that it's growing, then you want to get a good MRI with good resolution. And it's going to be easier to pick up 1 to 2 millimeters of growth. And the sort of the common rule we use around here is we all look at the imaging independently. The radiologist looks at it. I look at it, or Dr. Neff and our neurosurgery colleagues, and basically we all have to agree, is this tumor growing or stable? And that's kind of our ultimate decision about whether or not it's growing.
Okay.
I think the final point would be what we all want is volumetric analyses. So it is possible to do volumes, but it's a bit laborious right now. There's not good automated ways to actually calculate the volume of the tumor. Mm-hmm. But that is by far the most accurate way to look at changes in tumor size.
So vestibular schwannomas, as you know, typically happen on the vestibular nerve, which also meets up with the cochlear nerve. So outside of that and the fact that they occur on the same nerve, is there any relationship between hearing loss and balance? Like if you have hearing loss and it starts to increase, is there any relationship with increased disequilibrium or balance issues?
I think of the two problems a bit separately. Hearing loss is very related to size of tumor. There are always exceptions, very large tumors with great hearing and very small tumors with poor hearing. And in general, it correlates fairly well, or people with bigger tumors tend to have worse hearing. I think a balance probably more, we have two balance nerves, and these are very slow growing tumors. And so most people don't get the spins or vertigo, they get balance when I'm walking difficulties. And so I think of that more of as the more rapid a tumor is changing, the more trouble they may be having to adapt and have disequilibrium or balance problems. But that's not been studied quite as well, I don't think. But my gestalt is that faster growing tumors lead to worse balance trouble because they haven't had the time to adapt compared to a slow growing tumor.
Okay. One of the questions here in the question box talks about a side effect of Gamma Knife as hemifacial spasm. And this actually came up in the radiation talk that we had earlier today with Dr. Link, and it was one that we didn't get to. So it is, I know that he had said that facial issues after radiation are a very rare occurrence. But in this case, there is that hemifacial spasm. So the patient is asking, does that indicate any other problems in the future?
I say not necessarily, but just like all tumors that we treat with Gamma Knife, you're going to want to watch it pretty carefully. Mm-hmm. The overall, the risk of facial weakness or facial nerve problem is down in that 1% range. Mm-hmm. And so it is quite uncommon. I think a bigger tumor probably more likely to have trouble. That first 6 to 18 months when the injury from the radiation is maybe most acute and you get some rapid swelling of the tumor, I think that would increase, there's some risk then of hemifacial spasm or irritation of the nerve during that time. And if this person is Gamma Knife in 2013, now that I read the question, so this is 5 years out. So more commonly, you'd have symptoms early on, and then we'd be more optimistic that those would go away as the tumor stabilized and the tumor was treated. Mm-hmm. I would say hemifacial spasm 5 years after radiosurgery is a strong indicator your tumor is growing.
Yeah, and that one though, that's a different question.
Okay.
The one that we were talking about, I'm sorry, I put it in the email.
Okay.
Just so that I.
Yeah, you're right. Now that I read it.
Yeah,
I should read and answer questions at the same time.
Sorry, I'm moving things around. It's not making it easy for you. But so it doesn't talk about a time here. So I just wanted to clarify that.
Yeah, so hemifacial spasm would usually be in the shorter time frame and then would usually resolve with time. And so we would try to just ride it out. Mm-hmm. There are some medications sometimes the neurologist would prescribe. Most of those aren't super effective. And then go ahead.
I just wanted to pipe in that I totally agree with what Dr. Driscoll is saying. This is most likely radiation damage, or if it's 5 years out, worry about tumor regrowth or growth. But I would probably also ask my neurosurgeon to look to make sure, because people that don't have tumors get hemifacial spasm from vessels.
Sure.
Just make sure there's not a vessel that's been pushed up against the facial nerve that's could be amenable to some type of treatment that would give relief. But it would kind of surprise me if it was the cause.
Sure. Okay. Well, let's address this one where the patient had Gamma Knife in 2013. So basically, they had 2 sessions of Gamma Knife after regrowth, and now the patient is in their 80s and is wondering if there's regrowth a 3rd time. What are the options for treatment?
It's a good sign that it's been since 2018, the second treatment happened. There's been no regrowth, and we have had some success with retreatment. There's not a lot of long-term data on that, but that's at least encouraging.
Mm-hmm.
These tumors are very slow growing. We don't always have to treat them right away. But if your tumor got to a size where it's putting other things at risk or too much pressure on the brain, we can operate after radiation. And it's relatively straightforward, I'll say, to debulk the majority of the tumor and remove a lot of the volume. And that would, hopefully give you relief of any symptoms, or at least create a safer environment. So the treatment, if it failed a second time, which would be uncommon, would be surgery.
And we've talked a little bit in several different sessions about MRI and serial scanning, but I don't think and we've talked about getting scans without gadolinium, but I don't think at any point we've really discussed what the concern is with gadolinium. And there's a question about that. So what is the concern or risk with the continued use of contrast, typically gadolinium, in an MRI for post-treatment observation over a long period of time?
I can speak to this, and Colin can pipe in if he's got better information, he might. But I think it was a recent study out of here just showing gadolinium collecting in tissue throughout the body, and that it's kind of additive over time and number of scans. And I think what we don't know is, does that clinically mean anything? Does it lead to anything like early onset dementia or some other neurological condition? I don't think we can make that leap at this point. The initial data looks that it's quite safe, and there's really not an increase in those types of problems with gadolinium. But I think that's the concern that we don't have a super clear answer about right now. And so I think we haven't uniformly gone, and some people need contrast enhanced follow-ups for certain reasons, but if we're looking at somebody we're just following long-term, we are starting to, move towards, and Dr. Van Gumpel, one of our neurosurgeons here, is going to even pilot a project where we're using just the T2 high resolution sequences that don't need gadolinium to follow tumor growth. So if we can, it's not only that issue, but it's less costly. You don't need an IV. The scan is much shorter for those people that are claustrophobic. So there's a lot of other benefits for following with non-contrasted MRI scans if you're the patient that's okay to do it in, which a lot of the observation patients, that's where we're thinking about it.
I think MRI scanning has been around a long time, and gadolinium's been around a long time, and it's not clear there's any real consequences to it. There have been changes made into how the gadolinium is bound, and so the amount that's deposited seems to be much less now. At least that's what our neuroradiologists tell me. So they're trying to make it safer with the future. But the T2, the very high resolution non-contrast images can be really, really good for following tumors. That's not so good for following for evidence of recurrence after we've already operated.
We have a question on our Facebook page about a small acoustic neuroma, and symptoms are getting worse. And in this case, the patient's anxiety is becoming a factor, and they don't feel like they can deal with watch and wait. So They don't indicate the size, but are wondering if small acoustic neuromas can in fact be treated.
Did you want me to field it?
Either way.
So my understanding of the question is a small tumor is causing a lot of worry in a patient, and does it have treatments?
And can they really watch and wait just is causing too much anxiety.
I think that factors into the decision on the patient, what the patient should make. They really have, there's other factors, but I'm guessing that they probably have all three options available to them. And if they're really uncomfortable with the watch and wait, that is a legitimate reason to have it treated. I think it's a matter of discussing that with the surgeon that you're seeing and making sure they understand your priorities and the things that you're concerned about. And that is one thing that we see frequently push people towards surgical removal, for example, because the tumor and the patient are now in separate zip codes. So that makes them feel better.
It's not an uncommon scenario, frankly. We don't like to have tumors in our body. And so having anxiety around that is not unusual at all. And it can surface all the time because any little change in or perceived change in your hearing, a little change in your balance, oh, I have a little headache today, all those things you potentially then attribute to your tumor. So it's pretty easy that you worry about it all the time.
Yeah.
So it's totally reasonable to treat for that reason. And I think another thing that's been under addressed in our literature is really the psychological benefits of Dr. Neff being able to tell you at some point you're cured of your tumor. And, how does that makes us feel good as patients, right? And it's okay, I can close the chapter on that. And but I don't think anybody's really quantified the value of that.
Okay. There's a question in our chat, and it's an unusual situation where a patient had an acoustic neuroma removed long time ago, probably over 30 years ago. And then 30 years later, developed a small 7mm and on the right side, which took the hearing in that ear. And just how common is that? As far as she knows, there's no NF2. Is there a need? She says there's no need for genetic testing at this point because she's 66 years old, but is that the case or?
Yeah, well, that goes in the really unlucky category, certainly. And the vast majority of patients with NF2, well, a large number of patients with NF2 will show up early and have multiple tumors from the beginning. The diagnosis is very clear. I think all of us have seen people in their 60s. We had somebody just in her early 70s the other day who showed up for the very first time with some hearing loss, asymmetric hearing loss, and MRI scan showed bilateral tumors. So it can show up that way, but 2 episodes that far apart is really, really uncommon. And rare things can happen, but at my heart, I have to believe there's some genetic underlying predisposition for this person to develop schwannomas. Genetic testing could still be done just to see, is there an identifiable genetic source of the tumors, even though you're 66 years old? It is still something we would suggest pursuing to help us better understand the disease.
Okay. And another one on the chat here talks about a young patient who had a large tumor, 4.5 centimeters, was advised after removal that they should have the rest of it, the remaining tumor that was left behind, removed by another surgery rather than radiation if she wants to get pregnant. She's young. So we talked a little bit about pregnancy and radiation with Dr. Link this morning, and he talked about the fact that, since it's generally not an emergent situation, you could wait until after the pregnancy was over. But if there's patients who are still thinking about getting pregnant, is that an issue?
I don't, just in terms of the radiation and pregnancy, certainly if somebody was pregnant, we would wait until after birth, but I don't think it's otherwise an issue. Mm-hmm. So it's a one-day focused radiation treatment. It's going to have no effect on future pregnancies. Okay. Our general approach, you had a large tumor, we would have attempted to take out all of your tumor and preserve normal facial nerve function. If the tumor became very stuck to the nerve, or the nerve very splayed out and we were going to cause significant weakness, or felt we were going to cause significant weakness, we would have left a tiny bit of tumor on your facial nerve. And the idea then would have been to treat that residual with radiation. Okay. So that would be our approach, rather than go back 3 months or 6 months or a year later and try to remove the rest. So I think radiation for the residual, which looks, according to the question there, looks like a very small residual. So it appears, what I'm reading there seems to indicate they did a very good subtotal resection of your tumor, and you should be able to safely treat that small residual with radiation.
Okay. We have a question about the translab procedure, and if it's common to have eye and eyelid problems following that procedure. Is it more common than it would be with any other procedure, and is it common in general, I guess?
I'll field this one. I guess that I don't think it's any more common with that approach than the other approaches. And to me, it kind of makes a difference on what the eye trouble is. So if it's because there's a facial paralysis and there was maybe some tumor injury to the sensation nerve, people can get really dry eye and get problems with eye exposure. And I think the rates of that problem with facial paralysis are the same translab, retrosigmoid, or middle fossa. I think it could be other issues with the eye, depending on how large the tumor is. If it was a huge tumor that involves some of the eye movement nerves, then that's very unusual, but it's not so related to the approach. Mm-hmm. Then lastly, I would say that it's possible they could be talking about in the first few days. I have a lot of people say that their focus isn't very good because we just took a tumor out that's on their vestibular nerve. And so they have nystagmus, is where your eyes are jiggling around. Mm-hmm. And so I usually get a few days of complaints of trouble focusing, or it seems like my eyes are jumping around, and that usually resolves over the ensuing weeks. And I don't, again, think I think that was going to happen however you took the tumor out, if that was the problem, because every approach that we do, usually the nerve involved with the tumor comes with the tumor. And that's usually one of the balance nerves and it causes nystagmus.
Mm-hmm. Okay. There's a question about what I guess would be pretty quick growth. I know that you said you as a team look for 2 millimeters of growth within a year. And this patient is saying they had 5 millimeters of growth within 6 months. But their tumor is right now measuring at 1.5 centimeters. And they want to understand if they are still eligible or a good candidate for middle fossa and potential hearing preservation, because their hearing is still good.
So there's 2 approaches that can be utilized for hearing preservation. The middle fossa is one and retrosigmoid is the other. Mm-hmm. And a lot is made between whether, with which one's better. And really which one's better comes down to which one the surgeon who's doing the operation feels is better for them. Mm-hmm. They're both a little bit different in how you execute them, but at the end of the day, you're getting to the same tumor. And so a lot of tumors can be equally operated. We use the precise location, precise size a bit to help us determine which approach we might use. If it's a 1.5 centimeter tumor, then if that's really the 1.5 in inside the head, so plus the inner ear canal. We would remove that through the retrosigmoid approach. I think we get a much better facial nerve outcome that way. That's really starting to push the hearing preservation envelope. So less than a centimeter, we do reasonably well. Once they get above a centimeter, it gets less and less likely. The reality is you get in there and either the nerves are all lined up well and the planes between the tumor and nerves are good and the tumor comes out and the hearing's there, or things aren't lined up well and the hearing nerve and facial nerve are way separated or very sticky, and we just don't win that battle. So it's not too late. That's a rapidly growing tumor. We would lean towards taking it out. We would attempt to cure you, because we do feel like the failure rate with radiation is higher in rapidly growing tumors. So rapidly growing tumors that we radiate have failed radiation more often. So fast growing tumor, especially if you're otherwise youngish, healthy-ish, I would say we don't want to try and take it out.
Okay. You mentioned youngish. I have a question about dizziness that I want to ask, but there's another question on our Facebook page about the ideal age for radiation. And so I don't know that there is one, but is there an age when you say, no, I would not do radiation, or is it really open to all patients?
I'll give my opinion, and I believe Colin's probably the same. You can give your opinion if it's not, but there is not an age where we would say radiation is not a possibility. Mm-hmm. The younger you get, though, the better. It has to be a really good reason. So I think that NF2 patients, there's a little bit of worry. We certainly radiate NF2 patients, but very young patients with NF2, there is a little bit of worry that the radiation may have some negative effects down the road. So it really has to be some pretty good medical reasons in a very young person to want to do radiation, but it could also be that an NF2 patient with just an overbearing tumor burden, that some of them get radiation. So that I would say that it's case by case, but we don't have an age disqualifier on the young end. Certainly old ends, no. That, if you're 100, we probably are going to be watching it, or if it's growing, we're going to be doing radiation. So.
Okay. This question about dizziness asks why it continues even after the tumor has been removed, so in surgery. And the patient says she understands that there would be a period of retraining after particularly if the vestibular nerve is cut on the one side, that would cause dizziness. But then after that, if it goes, becomes sort of chronic, why does that continue?
I was waiting to see if Brian jumped in. So this maybe gets back to my very first point of this conversation, that we can't give back function that people have lost. So you had a tumor on your balance nerve, you lost your balance nerves, and that's going to come with consequences. Some people adapt really well. Very rarely do people tell us, or tell me anyway, my balance is normal after surgery. Most people will say, I still notice I have balance problems, I have some dizziness problems. And you hope that they don't really interfere with day-to-day activities, and that the person's allowed, it feels comfortable doing all their normal life activities. But the vast majority of people that have had acoustic neuromas operated on or radiated, or even many that have been followed, will have some dizziness or balance problems forever. That's just the nature of having a tumor on your balance nerves. And I think the odd thing is how people adapt is so unpredictable. And I think that has to do with our brains and just how they adapt to that change and how they rewire in response to the loss of function. And you can certainly help the brain to some degree by doing your rehab, doing your exercises. But I think there's something that's out of your control as well, and just how how our body responds to it. So it's a frustrating thing, and all you can really do is battle as much as you can, and then try and carry on doing the things you like to do in life.
Okay.
I had something I wanted to add. I totally agree with what was just said, and I think that's the vast majority of people struggling, that there is compensation that happens, but never back to perfect or normal. But in a few patients, I think Dr. Carlson in our group has some quality of life studies showing that how do we impact the dizziness symptoms and disability with surgery and radiation? And it turns out we don't impact it very much. And so possibly just because we're not restoring function, but I also think a lot of patients have undiagnosed or unrecognized problems causing dizziness going into it that have been blamed on the tumor and may not be recognized. And there's some super common stuff like vestibular migraine that patients probably have that just isn't diagnosed and then doesn't get better because it's unrelated to the tumor. And so I think a little bit of looking into that to make sure you don't have obvious vestibular migraine, or there's another condition that can develop in patients for chronic dizziness called persistent perceptual postural dizziness, becoming increasingly recognized as a cause for chronic dizziness. And there are certain history points that behavioral medicine doctors look for to say, is this happening? And so I think the vast majority of people, those aren't happening, but I think those probably need to be crossed off the list.
I think that's a great point. And just you don't want to blame all future dizziness on your tumor, because there are lots of other reasons to have dizziness, like blood pressure problems. So you don't want to ignore them and just attribute that to my tumor.
Okay. There is a question on here about tinnitus, and we've had lots of questions about tinnitus this week. This particular one changes pitch based on the way that the patient looks. So when they look left toward the tumor, it goes high, and it's a lower pitch if they look away from the tumor, and then similar changes if they look up or down. They're just wondering if there's any reason for that. I know everybody's tinnitus is kind of different. We've sort of explained over the course of the week what it is, but maybe you can talk a little bit about that.
Brian, I have no insight into that.
Off the top of my head, I can't think of the name of the person, so there's an eponym, but there is a description of patients with acoustic neuromas having changes in their intensity, looking right and left. I think they're in untreated tumors is kind of the 100 things to look for. But I don't know of an explanation for, however, because that's in the horizontal plane. I haven't heard that described in the vertical plane, or could say I really have a physiological explanation for that, other than I'm sure it's real and we just can't explain it.
Okay, and is there a difference when you get an MRI? Is there a difference between an open MRI or a closed MRI as far as the scan itself and what the result, you know, what you can read? Is there a recommendation as to you should get one or the other?
The more open, usually the more limited the resolution of the images might be, but there are open MRIs that are very good, and there are open MRIs that are not as good. At the end of the day, I mean, I think you want the non-open MRI if that works for you. Then you want the better versions of the open MRI, which means less open, you know, bigger but not biggest. So whatever you can tolerate. An open MRI is still going to be able to give a good diagnosis and be okay. So I guess I wouldn't get too worried about it. There's also a question here about T2 imaging and Fiesta or KISS. And I think it's strategy by the radiologist to not let us keep up and know everything they know. They change the names on a regular basis and add things. But we're pretty good at keeping up with them. So Fiesta and KISS are just the labels that different companies use for basically the same kinds of sequences. But if you look at an MRI scan, we'll get 10, 15, 20 different sequences, all different labels that all target the tissues in kind of different ways and give us different looks at the tissues. Only some of them are particularly helpful to Dr. Neff and I, but there's a lot of data in MRI scans, and these are just a couple of the variations. And it becomes important to understand what each imaging sequence is good at and what it's not so good at, because you have to interpret the colors on an MRI, which are pretty limited to sort of black, white, and gray.
Well, and there's another question on here about, it said that you said using only T2 high resolution scans without contrast is not good for seeing if a tumor is growing after surgery. And the patient is wondering, how about 5 years or more after Gamma Knife? Is that an effective kind at that point?
I think that the number one place that we're going to apply non-contrasted scans to follow is the observation patient. The number two place that we might do it is in the chronic non-growing post-radiation patient. So yes, I would consider it in that patient that's 5 years out from Gamma Knife that hasn't grown, and there's no controversy over that. Now, sometimes though, you're kind of worried it got a little bigger after radiation, and we may need contrast in some of those patients. So it's more case by case in the radiation. But if it was somebody that was 5 years out with a stable tumor, I would consider doing T2 only.
Okay.
There's some information we get with in the contrast in radiation. So you'll see that right after radiation, that first 6, 12, 18 months, you'll see some loss of enhancement in the center part of the tumor, which is what we expect. And then in some of the tumors that fail, you'll start to see that fill back in. And that kind of detail you might lose on non-contrast. But most of that, we're also looking for that earlier on. And so there is a point where, like Brian was saying, you're out 5 years. We were less interested in those kinds of things, and we're really just looking at size and volume. The bigger the tumor is, the harder it is to see the edges. So smaller tumors are really easy to follow with the T2 or non-contrast because you can see spinal fluid around it.
Okay, this is another unique situation, I think, in the sense that this patient has had other tumors that are not vestibular schwannomas, but meningiomas, and is taking care of those, but they keep coming back, and then also has an acoustic neuroma, and it's been radiated. It's at this point probably in the swelling stage, but she's very nervous, and her anxiety is high, and so she's just wondering what kind of things she needs to look for. She had lower lip numbness and numbness on her tongue, and that's gone away, but I would think that, people might be afraid that like you mentioned, every single thing has to do with the tumor. What should she be looking for?
I think that basically any new symptom that you're worried about, you want to talk with your surgeon or your radiation doctor about. A lot of them probably are things that could be unrelated to the treatment, or and I just to be afraid to, but like the hearing loss that happened the next day, it looks like in that question, we'd want to know about that so we could potentially treat it with prednisone. So I think you just have to lessen some of your worry by saying, I'm just going to communicate with my treating physician to say, is this something that's not to be concerned about, unrelated, or is this something you're worried about? And I don't think I'm expecting anything new in this lady, but if something new symptom comes up, please contact your treating physician.
Mm-hmm.
And there are other management strategies for anxiety and depression, and it's understandable that you're anxious. It's understandable that these things can lead to depression. Nobody's going to make the meningiomas and the acoustic neuromas and the tumors disappear. So somehow you have to work your way through that. And so I would seek out help to manage those symptoms alongside communicating with your team.
Okay. I don't know if you can see this question on here about the perception of speech or music. I've heard physicians that are specialize in balance issues talk about how having a balance issue can be described in so many different ways. Is that the same thing with hearing loss? So is this perception of speech or music, would that be considered tinnitus? I don't know if that happens with hearing.
So tinnitus is any sound that's there and perceived that others aren't perceiving. But not all things that are being perceived as tinnitus, if that makes sense. But I think any noise, buzzing, chirping, humming, clicking, all those I think are very typical tinnitus. Rarely we'll see in somebody with really bad hearing for a long period of time, they'll have a kind of musical description of it, or even say, I recognize certain melodies. And I think that's the brain inserting that meaning to that sound, rather than actually their hearing. So I have heard that before. Truly hearing speech and voices, though, is usually not what we consider tinnitus. That's something that isn't normal. Like if you're actually hearing words that are telling you something, that is usually psychological that needs to be discussed with your primary doctor about what could be causing this, but that's not something we consider to be tinnitus.
Okay. We talked in one of the earlier sessions about the use of endoscopes as a way to sort of sometimes see difficult angles or whatever once you're in, surgery. But we've also, as an organization, heard people talk about endoscopic surgery. And some people have talked about it when it is related to acoustic neuroma. So what do they mean when they say endoscopic surgery? And there is even a question about that. Is there a time you would use endoscopic surgery for an acoustic neuroma? I'm not sure I'm clear on, I thought the endoscope was a tool. And so I understand what they mean when they say endoscopic surgery.
Yeah, so the endoscope is a tool. And I'll just speak broadly about endoscopic surgery. So there are lots of cases we do where we do the whole surgery with an endoscope. So it's a tool, but it's used to accomplish the majority of the surgery. Or you can use the endoscope just as an adjunct to other instrumentation. So we look at it, it's a tool, and just like every other surgical tool we have, you find the times where that tool provides benefit and helps you execute the operation more effectively. If to do a fully what I would call an endoscopic tumor removal, maybe it's going to get too much in the weeds, but there are different ways you can do it. You can do a standard kind of retrosigmoid opening, and then you could use the endoscopes through that and take the tumor out. That's really rarely done. A microscope offers a lot of advantages in terms of two hands and depth perception. There's some work going on with endoscopic approach through the ear and through the cochlea itself to small tumors in the internal auditory canal. I'm struggling with why that provides any advantage at all to a standard approach through the back right behind the ear, which is a very direct and easy approach. a translabyrinthine approach, because either one's going to result in loss of hearing.
Mhm.
So there's always a lot of enthusiasm to try to minimize incision side or surgical trauma, and endoscopes sometimes allow us to do that. I think for all of us, we find the endoscope to be of pretty limited value
Mhm.
in acoustic neuroma surgery. And there's a lot of reasons for that. The one area that we do find it of value is the retrosigmoid approach, and trying to look out the internal auditory canal to see, do we get all the tumor out? Or sometimes you can see the plane between the nerves a little bit better with an endoscope. But it's not a magical instrument. It's an instrument like many of the others that we use.
Okay.
I have a quick thought on that is that I think there is some onus on the literature coming out about endoscopic surgery to prove that it's equivalent in its safety. And that's really why I don't think it's taken off, why I haven't adopted fully endoscopic surgery is that I just don't see how they would have the exposure for safety of unexpected bleeding.
Mhm.
And so everybody can show a film of their one great case of how, and we see this at meetings a lot, here's our one great case. And I say, I recognize that from the last meeting, but it's really more of the repetitive safety in hundreds and hundreds of people that I think is missing to say that it's equivalent exposure and safety for facial nerve and bleeding and things like that. So I use it as an adjunctive tool right now for seeing around difficult corners, not as a primary way of minimizing the incision.
Okay. Here's a question about, I know we don't say always or never, but this says, do you always recommend surgery over radiation in the case of a fast growing tumor, even if it's still small, and how do you define fast growing?
Yeah, fast growing in the study we did was 2.5 millimeters per year.
Mm-hmm.
So somewhere around that range. I agree with you that it's never an always or never. So it depends. We radiate fast growing tumors. We operate on fast growing tumors. It depends on the goals of that particular operation and the clinical setting. So it's just something to talk through.
Okay. There's a patient that is dealing with jaw pain after Cyberknife. So not Gamma Knife, what you guys have, but Cyberknife. And because of another tumor maybe that was radiated in that area, is there anything that they can do to alleviate that pain?
Yeah, I think that, so it's a little complicated question there. I don't know if that second tumor is really on the facial nerve or the trigeminal nerve, which supplies sensation to the face, which would be a little bit more likely given the symptoms they're having. Normally what would happen if this was really, it was 4 months ago that radiation happened. We would try to have you work with the neurologists and trial some of the medications that could be helpful for face pain. And that would be the next step. We would not rush into surgery.
Okay.
I think it matters on the size of the tumor and, whether the trigeminal nerve was affected. It could be a very small tumor that was radiated that has very little chance of being the underlying cause. So other things need to be looked at. Dental things that make your jaw hurt, and we're just correlating them in time, but they could be unrelated. But if it was a very big tumor that was rubbing that trigeminal nerve, then I think exactly, have the neurologist first try medications before you look at trying to decompress the trigeminal nerve with surgery after radiation.
And we are close to the end of our time. I'll go ahead and ask this last question because I've seen it a couple times this week. Is there any risk with radiation affecting the opposite side hearing?
We really don't think there's any risk at all. So the two ears are separated, and so there should be no risk with radiation. Okay.
Well, Dr. Driscoll and Dr. Neff, thank you so much for coming tonight, for spending this time with us, answering all these questions. This has been incredibly helpful. I want to thank everyone who's attended tonight and attended any presentation this week. This has been a really informative week. We've learned a lot, and we really appreciate you and everyone on your team for taking the time to help us sort of manage all of this. So thank you very much. And this week ends tomorrow. So it's a week, and we really appreciate all of the participation we've gotten from everyone. Thank you very much.
Thank you.
Thank you. Have a good night.
Thanks, you too.